Hello, my name is Jessica Pater. I'm a senior research scientist at Parkview Health, and I'm here to chat about our research paper charting the COVID long haul experience. So, what is COVID long haul? Many people who are diagnosed with COVID-19 never fully recover or take a long time to recover, thus, the kind of long haul component. These symptoms, consistent symptoms, or even sometimes new symptoms, can go on for weeks, months, even years after the initial infection. We call this COVID long haul, but it goes by a host of these names. And the commonality here is that this is an emerging chronic health issue. There are currently no diagnostic tests to test if you have COVID long haul. There are inconsistent approaches to treatment. And from the medical literature, we know that there's over 70 unique symptoms reported in connection with COVID long haul experiences. As of January 2024, we had more than 103 million documented cases of COVID in the US. And recent literature coming out of Lancet highlights that about 20% of these will develop some form of COVID long haul. So, what does that mean? Well, it means that over 27 million people have potentially been impacted by COVID long haul. A low subset, the 7.8 million plus, have symptoms that persist over 6 or more months. And then for an unfortunate 3.8 or more million, there are incapacitating symptoms like chronic fatigue or brain fog or neurological dysfunction that kind of augment and drastically change the way of life for individuals. So understanding this like complexity and kind of overwhelming wave of potential chronic illness, we decided we wanted to design a research study to get at a holistic understanding of what COVID long haul, the lived experience of patients really felt like, what it was. So in our paper, we had three main research objectives: to explore processes for capturing patient-reported outcomes and compliance data related to COVID long haul, how we could use commercial off-the-shelf technology within these processes, and explore the potential benefit and value of this data to patient well-being. We look at the integration of all of this data within our accepted CCW 2024 paper, which is led by Shaan Chopra. So to give you context of where this research is taking place, we're located in Northeast Indiana in the United States. And we have a partnership in our lab with our post-COVID clinic, which has been in operation since March of 2021, one of the first kind of 68 known post-COVID clinics in the United States. One of our tasks in this partnership is maintaining our data registry, which includes all of the EHR data related to certain aspects of the EHR data related to the patient, like comorbidities, demographics, diagnoses, et cetera, as well as patient-reported data to the clinic. So every patient is asked to submit their top 5 concerns or kind of symptoms and rank those by severity. So with this partnership with the clinic, we recruited 15 patients in early 2022 and observed them over a 3-month period of time. We had 4 different data streams: that initial EHR data. We had weekly survey data, which we'll get to in a second, daily Fitbit data for sleep and activity levels, and then exit interview data that were exit interviews that were mixed method. So in our weekly surveys, we had 3 main foci that we honed in on. One was those top 5 symptoms. Were those top 5 still their top 5? If not, what were the changes? What were the severity of those? Did those change? And were those individual symptoms getting better or worse, or not changing really at all? We then extracted the care plan from those the electronic health record encounter for the clinic. And for each of the recommendations in that care plan, were they making progress? Had they finished? Had they not started but planned on doing it? And then from a non-adherent side, were they not planning to do it, or did they think that the recommendation didn't really apply to them? And then how was their overall health? So I'm going to give a high level of some of the results, but encourage you to go to the paper to look for more granularity and detail. So we had to withdraw 1 patient due to lack of participation in surveys, but of our remaining 14, 3 reported no changes in symptom severity or the symptoms themselves. We see here with participant 22 that we had some new symptoms at the last week than we saw in the first week, and some shifting around of severity. We also saw some symptoms, collapsing. We didn't have as acute pain with hand and arm. It was more of a general pain by week 12. But with this individual, we saw a lot of complexity with what was getting better, what was getting worse. And unfortunately, after about midway point of the study, nothing was really getting better. And we saw more negative, getting worse week over week of their symptoms. When we looked at their care plan, as you can see here on the right-hand side, there were lots of different components to their care plan. So everyone was given 5 lifestyle recommendations. And those are things that they could easily do at really no cost to themselves. And additionally here, P10 could do orthostatic blood pressure and heart rate checks at home. Some things were a little bit more complex, like CBCs or seeing a speech therapist, whereas some were more invasive, like echocardiograms or sleep studies. In general, the average number of recommendations that were given to our patients were 16 to complete, and which seems like a lot, but these are kind of multifaceted chronic illness and thus might need different approaches and a constellation of approaches to kind of start addressing those top 5 symptoms. We see here that 2 of our 14 participants had complete compliance with their or complete adherence to their recommendations. Even if they hadn't yet started, they were not being non-compliant, reporting non-compliance. Whereas we had 2 other individuals who were non-compliant with all of their lifestyle recommendations and a good number of their clinical. Interestingly, when we went into the EHR to validate what we could from some of the clinical recommendations, 6 of the 14 participants had discrepancies between what they were reporting on their surveys and what we could find objectively within the electronic health record. Every patient was asked to get a COVID vaccination, and 8 of our 14 were compliant with this. They adhered to that recommendation. And the 6 that weren't adherent, we had assumptions going into their exit interviews of why they might not have been adherent. And what we found is those assumptions were false, were found to be false. Several had very definitive clinical reasons, either their doctor telling them not to or having severe allergies to vaccines. And several of our participants were just on kind of like a tightrope with their health. They couldn't handle one more thing happening or thing going wrong, and thus they chose not to take the vaccine so that just in case they were to have an adverse reaction. Other barriers to adherence, the most common we found was cost, either not having the funds for, expensive things like MRIs or specialty appointments, sleep studies, or having problems with our insurance companies not wanting to pay for some of the clinical recommendations. Another barrier was this kind of lived reality where if you're the sole breadwinner of your home and that's where you get your insurance through, you don't feel that you have the option to cut back at work or to do less because your insurance and your family's livelihood is depending on you being a full-time employee. Additionally, putting others and other things going on in your family before yourself. Our participants' health was also a barrier for us. 3 of the 14 participants were hospitalized during the 3-month study. Participant 19 was hospitalized multiple times and even answered the phone for her interview from her ICU room. And just shared that, she really wanted to be compliant with some of the recommendations, but just did not have the capacity because of the duration of her hospitalizations during the study. The Fitbit data, we found overall that our patients had less average steps than the daily recommended 10,000, with the exception of P23, who was a manual laborer and was on her feet all day. We had average or less than average sleep, less than the recommended 8 hours, and especially less than the recommended 10 to 20% of deep sleep, which is where the restorative and cell rejuvenation comes into play. And our patients across the board had much less than that kind of 10 to 20% of their sleep being in that deep realm. Yet, even though these were going on with their data, they really appreciated being able to see the data. Not all 15 of our participants, none of them really focused on wearing kind of Fitbits, Apple Watches, those types of thing, and tracking their daily activity. So it was really helpful for them to see that kind of be able to see the progress overall, even if maybe they weren't making progress at that minute or at that exact second. When we connect the Fitbit data with other aspects, we see that higher levels of care plan adherence had higher levels of average daily sleep and like the lowest levels of daily activity. And those reporting low overall health had the highest also daily sleep and the least amount of physical activity. So a lot of interesting kind of connections when you start going between adherence and self-reports and then the objective Fitbit data. Without being prompted during our interviews, this idea of new normals came up quite often, almost half of our participants. And a lot of this were physical capabilities, like needing to take a break or sit down after taking a shower because of the extreme exhaustion and fatigue, the change to their daily tempo, not being able to be up on their feet for 8, 10, 12 hours, and the kind of what the impacts that had on their daily life. Not having had any chronic illness before getting COVID and now identifying as someone with a chronic health issue. And then having to kind of learn how to communicate this new normal to doctors, coworkers, family, friends, supervisors, many of which might not understand or even believe that this is a real thing and what that means to kind of you in your daily life. So what does this mean from what role does technology have within the COVID long haul milieu? One of the things that we saw across the board was this idea of validation, having those data feedback from the Fitbits and from the surveys, validating what they were feeling internally, whether they were getting better or if they were actually not getting better, they were getting worse. And the Fitbit data, their sleep data actually highlighting and kind of corroborating that. We also saw that our patients were going online and researching COVID long haul because most of the time they were the only person in their social networks or their ecosystems that were having these like really long chronic issues. And we know from our previous, some of them also use social media for like support groups and just finding, like-minded people to give them that support. And we know from a lot of previous HCI research, especially around health, just the impact that social media can have for social support of kind of rare or chronic illnesses in general. Also, we had this idea of visibility that the technology and the data shed light on certain aspects of their health and allowed them to share data back with their doctors, their general doctors. That gave them more insights into what was happening that they were sharing, not just with our post-COVID clinic, but other doctors in their network. And then, of course, helping kind of define this new normal. Because we had such different data streams, we were able to triangulate between them and have some really interesting thoughts around that. So we had this where the EHR was refuting some of the survey claims. And while we can't, definitively say that they were not being as truthful on their surveys, they could have been receiving care in other health systems. And because of the way that these federated systems are siloed and don't communicate back and forth with one another, it makes trying to get a holistic understanding of somebody's health, especially complex health, where not everything is being taken care of within one given system, really complicated. We saw that because of our mixed method approach, the qualitative data we collected helped give us context to kind of critical aspects of our survey and challenge some of our common assumptions, as we saw with kind of the COVID vaccination adherence. We also saw that the objective clinical data can tell incomplete stories sometime. And with participant 23, who was our manual laborer, who the objective data through her Fitbit and her sleep data, her activity and sleep looked great, but like her subjective data of what she was reporting, she was getting worse and worse and worse throughout the study period. And a lot of that was due to the environmental factors of her overworking her system and having these kind of complex environmental influences from both her home life and at her work that were having deleterious impacts to her overall health that we were tracking during the time. And then, of course, non-adherence is not necessarily problematic. I would state that there were a lot of challenges that we outlined in the paper, and I would encourage you to look at that are related to some of our methods and some of the issues we had with our patients and their mental health disclosures during the study. But with that, I just thank you for your time and attention today and for the funding from a private donation through Parkview that allowed for this work to take place, and for the countless people that silently and maybe not so silently struggle with COVID long haul on a daily basis. Thank you so much.